So we're going to redo this because I don't think the first recording went very well. So infection and immunity. My name's Chantel Manhart. I work for Northern Illinois University. We're going to cover Chapter 6, Innate Immunity, Inflammation, and Wound Healing. Okay, so if we're talking about immunity, the body is under constant assault by life-threatening microbes. Although the vast majority of microbes are harmless, occasionally they're not. So we have the immune system, which is responsible for protecting the body against an array of microorganisms, such as bacteria, viruses, fungi, to name a few, as well as removing damaged cells and destroying cancer cells. The immune system provides this protection by defending and attacking. So the immune system takes multiple approaches to protecting the body from antigens, including the use of innate and adaptive defenses. So our innate immunity is our first line of defense, and it's our natural or native immunity. And it is, if you're talking innate immunity, it provides immediate protection, and it's non-specific, meaning it provides protection against all kinds of invaders. And so it's going to use physical, mechanical, or biochemical barriers. Then we have our second line of defense, which is inflammation. And then our third line of defense is adaptive or acquired, and it's more specific immunity. And it can take up to 7 to 10 days to provide protection, but it's very specific to the antigen. So when we're looking at our first line of defense, we're looking at the physical barriers, which is skin and mucous membranes are at the top. So what happens is the epidermal cells is a thick, impermeable layer overlaying a rich and vascular layer known as the dermis. As newly protected skin cells push the dead ones outward, the dead cells produce a waterproof layer, and then that becomes known as keratin, and this contains dead cells. And so when you think about this, it's trying to protect us. But the skin does have a protective, it does protect us. It does have, we're a human body, and it does allow microbe invasion through some passageways because it allows direct access into the body through different ways. We have our interior respiratory system, digestive system, and our genitourinary tract. And we also have the physical barriers, which include chemical barriers to prevent invasion. And for example, we have the skin that produces a slightly acidic substance that inhibits bacterial growth. We have hydrochloric acid in the stomach, which destroys many of the ingested bacteria. We also have additional blood-borne innate defenses, which are in place to respond to those antigens, including the inflammatory response, pyrogens, interferons, and we have the complement proteins. So if you think about it, we have lots of different ways that we try to protect our body. We have the coughing, the sneezing, We even vomit to protect our body. And we have also our normal flora, which is in place to protect our body too. It's really amazing how much of our first line defense is protective. So, our second line of defense, inflammatory response, the first immune response to injury is nonspecific, caused by a variety of materials, infection, tissue necrosis, trauma, physical or chemical injuries, foreign bodies, immune reaction, ischemia. Local manifestations: redness, heat, swelling, pain, and loss of function. Then we get the inflammatory response. It occurs in tissues with a blood supply, is activated rapidly after damage occurs. It depends on the activity of both cellular and chemical components. Is nonspecific, meaning that it takes place in approximately the same way, regardless of the type of stimulus. And then we're going to get vascular response. So those blood vessels dilate, increasing blood flow to the injured site. And this response is triggered by some mediator or mast cells, including histamine and prostaglandins. Immediately after the injury, arterioles in the area briefly go into spasm and constrict to limit bleeding and the extent of injury. This vasoconstriction is immediately followed by vasodilation, which increases blood flow to the injured area in an attempt to dilute toxins and provide the area with essential immune cells, nutrients, and oxygen. The vasodilation increases capillary permeability. As permeability increases, leukocytes line the vessel walls in preparation for the migration into the surrounding tissue. While the leukocytes are lining the vessel walls, endothelial cells in the vessel walls react to the biochemical mediators that cause these vessels to retract. This retraction gives the leukocytes enough room to migrate into the interstitial space and begin the cleanup process of phagocytosis, or the engulfing of the digestion of the foreign substance and the cellular debris. In conjunction with the phagocytosis, fibrinogen or transformation into fibrin. This fibrin is used to wall off the injured area so that the foreign substances are contained. A meshwork of new cells forms to provide support for the healing process. So the goal and control of the inflammatory process is the influx of the plasma protein system and the plasma enzymes and the cell preventing the inflammatory response from spreading the areas of healthy tissue, prevent the limit infection and further damage. The inflammatory exudates dilute toxins produced by bacteria and released from dying cells. The influx of phagocytes destroys cellular debris and microorganisms. It initiates adaptive immune response and responds to the contaminating pathogens through the influx of macrophages and lymphocytes that destroy pathogens. Initiate healing and repair through removal of bacterial products, dead cells, and other products of inflammation. Cellular components. When looking at the cellular components of inflammation, each cell has a part to play. Erythrocytes carry oxygen to the tissue. Platelets are small cell fragments involved in blood clotting. Leukocytes are subdivided into granulocytes. Most common leukocytes are classified by the types of stains needed to visualize the enzymes containing granules in their cytoplasm. Macrophages that are found in the tissue. Monocytes are the precursors of the macrophages found in the tissues. Lymphocytes are innate immune responses and acquired immune response. Cellular receptors, B and T lymphocytes, of the adaptive immune system have evolved surface receptors that bind a large spectrum of antigens. Pattern recognition receptors recognize two types of molecular patterns: the molecules that are expressed by infectious agents, either found on their surface or released as soluble molecules, or released as soluble molecules or products of cellular damage. Pathogens associated molecular patterns, or allowed cells of innate immune systems, can respond to both sterile or septic tissue damage. Damage-associated molecular patterns, toll-like receptors, primarily recognize a large variety of PAMPs located on the microorganism's cell wall or surface, other surface structures, or microbial nucleic acid. 10 different TLRs have been described in humans. Complement receptors are found on many cells of the innate and acquired responses. Scavenger receptors are primarily expressed on the macrophages and facilitates recognition and phagocytosis of bacterial pathogens, as well as damaged cells and altered soluble lipoproteins associated with vascular damage. NODs, like receptors, are cytoplasmic receptors that recognize products of microbes and damaged cells. Cytokines are responsible for activating other cells and regulating inflammatory response. Chemokines are synthesized by many cells, macrophages, fibroblasts, endothelial cells, in response to pro-inflammatory cytokinase. They induce chemotaxis to promote phagocytosis and wound healing. So examples of this is monocyte macrophage chemotactic proteins, macrophage inflammatory proteins, or neutrophils. So interleukins are produced primarily by macrophages and leukocytes in response to stimulation of PRRSs or by other cytokinases. There are many different types. So your interleukin 1 regulates fever. Your interleukin 10 is primarily produced by leukocytes and suppresses the growth of other lymphocytes and the production of pro-inflammatory cytokinase by macrophages, leading to downregulation of both inflammatory and acquired immune responses. So interferon protects against viral infections. It's produced and released by virally infected host cells in response to viral double-stranded RNA. It protects neighboring healthy cells. The types are IFNA alpha and IFNA beta. Its induced production of antiviral proteins. The IFN Y is increased microcytal activity of macrophages. So when we're talking mast cells are cellular bags of granules located in the loose connective tissue close to blood vessels. They include skin, digestive lining, and respiratory tract. They contain histamine, cytokinase, and chemotactic factors. They have chemical release in two ways: degranulation, the release of the contents of mast cell granules, or synthesis, the new production and release of mediators in response to a stimulus. So if it's synthesis, those are including leukotrienes, prostaglandins, platelets, and activating factors. So when we're talking mast cell degranulation, we're talking histamine. So vasoactive amine that causes temporary rapid constriction of the large blood vessels and the dilation of the post-capillary venules. You get reaction of the endothelial cell lining the capillaries. So you get the reaction of the endocell lining of capillary receptors. And so, like you get your H1 receptor, which is pro inflammatory, which promotes inflammation. And it's going to be present in your smooth muscles of the bronchi. And so then you're going to get the bronchoconstriction. Or you can have your H2 receptor, which is your anti-inflammatory suppression of your F leukocyte function, which is present on the parietal cells of the stomach mucosa, which induces the secretion of gastric acid. So mast cell granules also contain chemotactic factors, two of which are neutrophil chemotactic factor and eosinophil chemotactic factor of anaphylaxis. Chemotaxis is directional movement of the cells along the chemical gradient formed by a chemotactic factor. So neutrophils are the predominant cell needed to kill bacteria in the earlier stages of inflammation, and eosinophils help regulate the inflammatory response. This is just a pictorial to show you the mast cell degranulation. Sometimes I think a picture helps. So you have your synthesis of mediators, which is leukotrienes, which is a product of the arachidonic acids, from the mast cell membranes. Similar effects to histamine in later stages. Slower, more prolonged effect than histamine. And so then you get your prostaglandins, which has the similar effect to leukotrienes. They also induce pain by effects on nerves. So aspirin and some other non-steroidal anti-inflammatory drugs are really good at blocking the synthesis of prostaglandins. So thereby inhibiting inflammation and pain. Then you've got your platelet activating factor, which is similar effects to leukotrienes and platelet activation. Or your PAF is produced by removal of fatty acids from the plasma membrane, phospholipids by phospholipase A. Although mast cells are a major source of your PAF, this molecule also can be produced by neutrophils, monocytes, endothelial cells, and platelets. The biological activity of the PAF is virtually identical to that of the leukotriene. When you're talking about the endothelium, your endothelial cells adhere to underlying connective tissue matrix. They interact with cellular circulating cells, platelets, plasma proteins. They regulate circulating inflammatory components. Damage to these initiates platelets adherence. So, platelets activate by tissue destruction and inflammation. They interact to stop bleeding, deregulate releasing biochemical and mediator such as serotonin, such as a vascular effect similar to those of histamine. They synthesize thrombo, um, thromboxane A2 from prostaglandin H2TXA2. Is a potent vasoconstrictor and inducer of platelet aggregation. The low dose aspirin will suppress the production of the TXA. So neutrophils, they're predominantly phagocytes in the early inflammatory site, arriving within 6 to 12 hours after early inflammatory injury. Their primary role of the neutrophils are the removal of debris and dead cells. These cells do not live long, and then they become part of the purulent exudate or pus, which is removed from the body through the epithelium or drained from the infection site via the lymphatic system. So eosinophils, the role of the eosinophil is resistance to parasites occurring in collaboration with specific antibodies produced by the acquired immune system. It's only mild phagocytic. It does serve as the body's primary defense against parasites. It helps regulate vascular mediators released from mast cells. Monocytes are produced in the bone marrow. They enter circulation and migrate to the inflammatory site where they develop into macrophages. They arrive to inflammatory site 24 hours later than the neutrophils, and they are the largest normal blood cell. So eosinophils, dendritic cells, and T lymphocytes. Eosinophils are body's primary defense against parasites. They help regulate vascular mediators released from mast cells. Our dendritic cells are one of the major links between innate and acquired immune responses. They are primarily phagocytic cells located on the peripheral organs and skin, where molecules released from infectious agents are encountered, recognized through the PRRSs, and internalized. Through phagocytosis. They will migrate through the lymphocytic vessels to lymph node tissues, such as lymph nodes, and interact with the T lymphocytes. To generate an acquired immune response. Our T lymphocytes were generally due to an acquired immune response. They, through the production of a family of cell kinase, they guide the development of a subset of T cells and coordinate the development of functional B and T cells. So, phagocytosis. Throughout the phagocytosis process, both the target and the digestive enzymes are isolated within the membrane-bound vesicles. Isolation protects the phagocyte itself from the harmful effects of the target microorganism as well as its own enzymes. You will see that it has marginization, adherence of the leukocytes to the endothelial cells, dipedesis, which is emigration of the cells through the endothelial junctions that have loosened due to the inflammatory process. The different steps are adherence, engulfment, phagosomal formation, fusion of lysosomal granules, destruction of the target. So, acute inflammation is self-limiting. Local manifestations result from vascular changes and corresponding leakage of circulating components into the tissue. Heat, swelling, redness, pain. Um, Exudative fluids will consist of serous exudate, fibrinous exudate, purulent exudate, hemorrhagic exudate. Exudative fluid, serous exudate, watery exudate indicates early inflammation. Fibrinous exudate, thick clotted exudate indicates more advanced inflammation, and purulent suppurative pus indicates a bacterial infection. Obviously, hemorrhagic exudate contains blood, indicates bleeding. Systemic manifestations of acute infection include fever, leukocytosis, plasma protein synthesis. So chronic inflammation lasting 2 weeks or longer, often related to unsuccessful acute inflammatory response. It can be characterized by pus formations, or incomplete wound healing. Other causes of chronic inflammation can be high lipid or wax content of a microorganism, ability of survival of inside macrophage, toxins, or chemical chemicals, particulate matter, or physical irritants can all be signs of chronic inflammation. This is just a pictorial of chronic inflammation. So wound healing, our first one is regeneration. And so regeneration is the replacement of damaged tissue with healthy tissue. And that can occur with the replacement of like epithelial of the skin, or like certain organs can regenerate themselves, such as the liver. And then we go into resolution. And resolution is, if you think about restoration, and this can take up to 2 years, and that's where resolution may be possible or it may not be possible, but it's where you're trying to return the injured tissue back to its like previous state, is what you're hoping to do, or into its original structure. Then you go into repair, which is replacement of destroyed tissue with scar tissue, essentially. And scar tissue is essentially composed of collagen that fills in the lesion and restores it to a strength, but it'll never be the same physiological strength or function as it was. And debridement's where if there's an infection that we have to go in and start to remove some of the fill-in of tissue to remove like infection and take it down to healthy tissue, which is usually not a very pleasant procedure if any of you have been involved in that. And then healing is where the wound itself is healing, it's being filled in, it's sealing, and the wound is starting to shrink and repair. So healing is where we get the composed of filling of the wound, sealing of the wound, shrinking of the wound is considered healing. So wound healing can happen a couple of different ways. We have primary intention, which is minimal tissue loss and close approximation of the wound edges. Very little sealing, shrinkage are required. Then we have secondary intention. These are wounds that have to heal unsutured by the inside out. And with this, the tissue regains only 80% of its original tensile strength. And a lot of times these are going to be wounds we've either packed to help them heal from the inside out or have used wound vacs with. So when we're talking wound healing, there's different phases. Phase 1, Phase 2, Phase 3. So Phase 1 is the inflammatory phase, and this includes coagulation or hemostasis and the infiltration of cells that participate in this wound healing. This can include platelets, neutrophils, and macrophages. And it's going to be where typically you're going to get fibrin, mesh, blood clots act to get cells that are all participating in healing. Then you're going to get this phase 2, which is a proliferative phase, and it's characterized by macrophages invasion of the dissolving clot, and it's going to end up recruiting and proliferation of fibroblasts, connective tissue, and collagen. So you're going to end up getting more where you're getting transformation of stimulation of the fibroblasts entering the lesion. Then you have to have angiogenesis factors where you get vascular endothelial growth factors and fibroblast growth factor 2 to stimulate vascular endothelial cells to form capillary buds. And then you have to get your matrix metalloproteinase, which is your MMPs, to degrade and remodel extracellular matrix proteins, which is collagen and fibrin, at the site of the injury. Then you're going to have granulation tissue grow into the wound and form surrounding healthy connective tissue, so that you get this fill-in for that. Then you've got your phase 3, which is your remodeling and maturation phase. And tissue remodeling and maturation begins several years after injury and is normally complete within 2 years. And this is going to consist of cell differentiation, scar formation, remodeling, and tissue remodeling, and maturation phase, and recovery of some normal tissue structure for it to persist for years. I like this pictorial because it kind of shows you how everything is interconnected and how it starts to heal. And I like the left is showing you primary intention, the right is showing you secondary intention. And all you have to do is hear all the different phases and everything that can go wrong with wound healing. And we have dysfunction during inflammation. So excessive bleeding can hinder it. Excessive fibrin deposition. Disposition disorders. So if somebody's got diabetes, that hinders it. If somebody's obese, that can hinder it. A lot of times we'll get dehiscence of wounds, wound infection, inadequate nutrition. So if they've got a poor diet, it's not going to heal correctly. If they take numerous drugs, that hinders it. If they smoke, that hinders it because then they don't have the capillaries and to get the cells where we need them. So then dysfunctional wound healing. So when we're talking dysfunctional during reconstructive phase, we can have dysfunctional collagen synthesis. So that's when you're talking, you're going to get the keloid scar or the hypertrophic scar, or wound disruption, which is that dehiscence, which causes increased risk of infection. Or you can get impaired contraction. So when you start getting contractures with wounds, that's not good either. I think this is just a good example of showing you some really good dysfunction of wound healing with the keloids. Chapter 7, Adaptive Immunity. Okay, so adaptive immunity. The third line of defense in the human body is adaptive or acquired immunity, often called the immune response or the immunity, and consists of lymphocytes and serum proteins called antibodies. Adaptive immunity is inducible. The effects of the immune response, lymphocytes and antibodies, do not preexist but must be produced in response to infection. Thus, adaptive immunity develops more slowly than inflammation. The immune response is exquisitely specific. The lymphocytes and antibodies induced in the response to infection are extremely specific to the infecting microbe. The effects of the immune response are long-lived and systemic, providing long-term protection against specific infections. The immune response has memory. If reinfected with the same microbe, protective lymphocytes and antibodies are produced immediately, thus providing permanent long-term protection. The adaptive immune response has its own vocabulary. Antigens are the molecular targets of antibodies and lymphocytes. Antigens are generally small molecules, usually within protein, carbohydrates, or lipids found on the surface of the microbes or infected cells, although thus definition work be expanded as we discuss immunologic disease. There is a breakdown of lymphoid stem cells into T lymphocytes and B lymphocytes. So as we're talking adaptive immunity, we're going to talk about components. So humoral immunoglobulin antibodies. Antibodies circulate in the blood and defend against extracellular microbes and microbial toxins. These refer to as the humoral immune projected or humoral immunity. They bind to antigens on bacteria and viruses. Cellular T cells. Subpopulation is the effector T cells. They defend against intracellular pathogens. They're going to kill target directly, and they stimulate other leukocytes. They both produce memory cells, and they interact. Okay, so as we're talking about adaptive immunity response, has its own vocabulary. Antigens are the molecular targets of the antibodies and lymphocytes. Antigens are generally small molecules, usually within the protein, carbohydrates, or lipids found on the surface of microbes. Some lymphoid stem cells enter the thymus and differentiate into T lymphocytes or T cells, whereas others specific region of the bone marrow and differentiate into B lymphocytes. B indicate bone marrow derivative or derived. Each type of cell develops origin-specific cell surface proteins that identify them as T or B cells. Active immunity, which develops in response to antigens. Passive immunity is included individual exposure to an infectious agent without having a pre-existing vaccine-induced immune infectious agent. So without having a pre-existing vaccine-induced immunization, immunogen will give only when we feel it is needed. So, humoral immunity. Antibody and immunoglobulin are frequently used interchangeably. It's a product of plasma cells, so there's different types. So your IgG is the most abundant and most protective, circulates in the body fluids attacking antigens. IgA is found in the secretions on mucous membranes, prevents antigens from entering the body. IgM is the largest of the IgGs, circulates the body fluids and able to clump antigens together. IgE is found on mast cells and tissues, initiates inflammation. Your key IgG in allergic reactions and defends against its key IgG in allergic reactions and defends against parasites. IgD is found on the surface of B cells and acts as antigen receptor. This just gives you a pictorial of what each one of them looks like. So your secretory or your mucosal immune system is a primary response. Initial exposure. It has a latent or lag phase. Its B cell differentiation is occurring. After 5 to 7 days, an IgM antibody for a specific antigen is detected. An IgG response equal or less, slightly less, follows the IgM response. So, during the secretory mucosal immune system, the lymphoid tissues on the external surface of the body set up a network of protections. Your antibodies are secreted in tears, sweat, saliva, mucus, and breast milk to prevent infection. IgA is the dominant secretory immunoglobulin. IgM and IgG are present in the secretions in smaller numbers. Maternal antibodies that pass across the placenta into the fetus before birth provide passive systemic immunity. Antigen processing and presentation. So the immune response occurs in two phases: the generation of clonal diversity and clonal selection. Clonal diversity is the production of a large population of B cells and T cells before birth and having the capacity to recognize almost any foreign antigen found in the environment. This process mostly occurs in specialized lymphoid organs, the bone marrow for B cells and the thymus for T cells. The result is the differentiating of lymphoid stem cells into B and T lymphocytes with the ability to react against almost any antigen that will be encountered throughout life. The B cell receptor is complex of antibodies bound to the cell's surface and of molecules involved in intracellular signaling. Its role is to recognize antigens and communicate the information to the cell nucleus. The T cell development is the thymus. They are driven to undergo cell division and simultaneously produce receptors against the diversity of antigens the individual will encounter throughout life. To initiate the effective immune response, most antigens must be processed because they cannot react directly with most cells of the immune system and thus be shown or presented to the immune cell in a specific manner. T lymphocyte function in the activation of other T and B cells, in the control of intracellular viral infections, rejection of foreign tissue grafts, and delayed hypersensitivity reactions, cell-mediated immunity, mature T cells, CD4 helper, CD8 cytotoxic. Helper T cells help the activation of other immune cells by releasing T cell cytokinase. Cytotoxic T cells kills cancer cells, cells that are infected primarily with a virus, or cells that are damaged in other ways. The job of antigen process cells, generally referred to as APCs, the interaction among APCs subpopulation of T cells that facilitate immune responses and immune competent B or T cells result in differentiation of B cells into active antibodies, producing cells, and T cells into effector cells such as T cytotoxic cells, both line development into memory cells and respond even faster when the antigen enters the body again. So, MHC antigen presentation. So, MHC molecules are glycoproteins found on the surface of all human cells except red blood cells. They are divided into two general classes, class 1 and class 2, based on their molecular structure, distribution among cell populations, and function in antigen presentation. Class 1 endogenous antigens are recognized by T cytotoxic cells, will result in foreign antigens being present. MHC class 2 molecules present in exogenous antigens is preferably recognized by T helper cells, co-expressed with MHC class 1 molecules on a limited number of cells that have APC function, including macrophages, dendritic cells, and B lymphocytes. So your MHC major histocompatibility complex are called human leukocyte antigens and are related to their role in transplantation. MHC1 displays antigens are made inside an infected cell. MHC1 tells the cytotoxic cells to kill the infected cell before it can infect others. MHC2 display antigens eaten by phagocytic cells. MHC2 tells the T helper cells to start an immune response against the antigen. So, your primary and secondary responses. Your primary response is initial response. It's 5 to 7 days. An IgM antibody for specific antigens detected. Your IgM antibody is detected in circulation, followed by IgG antibody of equal value or less. Values will fall. Your B cell differentiation is occurring. Your secondary response is a more rapid. IgM may be transiently produced. Larger amounts of antibody. IgG produced is increased considerably. Your IgM remains the same. Rapidity is caused by the presence of memory cells that do not have to differentiate. So the secondary response is usually caused by a vaccine. Which is why we get a better response. Cellular interactions in the immune response. Intracellular collaborations resulting in the production of effector cells and memory cells require 3 complementary intracellular signaling events. There's antigen-specific recognition through the TCR complex. There's activation of the intracellular adhesion molecules, and there's response of the specific groups of cytokinase. So the T helper lymphocytes help the antigen-driven maturation of the B and T cells. They facilitate and magnify the interaction between APCs and immunocompetent lymphocytes. So, for the most part, antigens and the first step in the clonal selection is the process and presentation of the APCs. So, antigens are usually expressed on the large molecules found on the microbes, which undergo the phagocytosis and the destruction of the dendritic cells and macrophages. This is by exogenous antigens. The MHCs are glycoproteins found on the surface of the human cells, except red blood cells. They deface into two general classes. The Th1 cells provide help in developing immunity, and so we see that helps develop the cell-mediated immunity, and the Th2 cells provide more help for developing cell humoral immunity. And then there's differences based on the cytokinase production. Then the steps of the Th interacts through the antigen-dependent mechanisms that undergo differentiation. Mature Th interacts with plasma on T effector cells. So T lymphocyte function. The clonal selection process produces several subsets of effector T cells. The cells and T memory cells have already been discussed. So the T cytotoxic cells that attack and destroy cells express antigens from intracellular origins. The T regulatory cells has limits. The immune response and the T lymphokine producing cells that secrete cytokinase that activate other cells. So, like the natural killer cells are a special group of lymphoid cells that are similar to the T cells but lack antigen-specific receptors. So instead, they express a variety of cell surface activation receptors to identify protein changes on surface of cells, to reinfect with viruses or that have become cancerous after attachments. So like the NK cell killer kill its target in a manner similar to that of the TC cell, the NK cell kill its target in a manner class 1. However, the NK cell lacks CDs, therefore binding to the MHC class 1 molecules, resulting in inactivation of the NK cells. Thus, NK cells complement the effects of TC cells. In some instances, a virus-infected or cancer cell will protect itself by downregulating. So, Chapter 8, Infection and Defects in Mechanisms of Defense. So modern medicine has made great strides in preventing and treating infectious disease, but we still have endemic diseases such as chronic hepatitis, HIV, and foodborne or STIs, foodborne infections. The most vulnerable groups are our elderly and our children and those with chronic diseases. Influenza has already taken 114 lives of infants and children this year, and we just started the flu season. Sepsis is still very high, which is why most hospitals now have a sepsis protocol to try to catch it early. Microorganisms and humans, a dynamic relationship. So, increase in antibiotic resistance in particular places more impact on maintenance of an intact inflammatory and immune system. Several factors influence the capacity of a pathogen to cause disease. Communicability, the ability to spread from an individual to others. Measles and pertussis spread very easily. Infectivity is the ability of pathogen to invade and multiply in the host. Herpes simplex can survive for long periods in a latent stage. Virulence, capacity of a pathogen to cause severe disease. Measles virus is of low virulence. Rabies and Ebola viruses are of high virulence. Pathogenicity, the ability of an agent to produce disease. Success depends on the communicability, infectivity, or the extent of tissue damage and virulence. HIV can kill T lymphocytes very quickly. Portal of entry, route by which a pathogenicity microorganism infects the host. Direct contact is inhalation, ingestion, or bites of an animal or insect. Toxogenicity is the ability to produce soluble toxins or endotoxins. Factors that greatly influence the pathogen. Degree of virulence. Infectivity is facilitated by the ability of the pathogen to attach to the cell surface, releasing enzymes that dissolve protective barriers, multiply rapidly, escape the actions of phagocytosis, or resist the effects of low pH. So we have factors for infection. The communicability is the ability to spread from one individual to others and cause disease. Immunogenicity is the ability of pathogens to induce an immune response. Infectivity is the ability of the pathogen to invade and multiply in the host. Pathogenicity is the ability of an agent to produce disease. And mechanism of action is how the microorganism changes the tissue. Portal of entry is the route by which the pathogenic microorganism infect the host. Toxogenicity is the ability to produce soluble toxins or endotoxin, factors that greatly influence the pathogen's degree of virulence. Virulence is the capacity of the pathogen to cause severe disease. Pathogen defense mechanisms. Bacteria. Bacteria are prokaryocytes and are relatively small. They are aerobic and anaerobic, are motile or immotile. Viruses are very simple microorganisms consisting of nucleic acid protected from the environment by a layer or layers of protein. The viral genome can be double-stranded or single-stranded RNA. Bacterial disease are toxin production, exotoxins, enzymes that can damage the plasma membranes of host cells and can inactivate enzymes critical to protein synthesis. Endotoxins activate the inflammatory response and produce fever. Endotoxins are usually typically gram-negative. Bacteremia is the presence or septicemia, growth. It's a result of failure of the body's defense mechanisms, usually caused by a gram-negative bacteria. Endotoxins released into the body activate the complement and clotting system, leading to a degree of capillary permeability sufficient to permit escape of large volumes of plasma into the surrounding tissues, contributing to hypotension and, in severe cases, cardiovascular shock. Bacteremia can cause endotoxic shock, which has a 50% mortality. So, viral disease. The life cycle of every virus is completely intracellular and involves several steps. The first being attachment of a receptor on the target cell. Attachment is followed by penetration, entrance into the cell by endocytosis or membrane fusion, uncoating, release of viral nucleic acid from the viral capsid by virus or host enzyme, replication, synthesis of mRNA and viral proteins, assembly formation of new viron and release exit from the cell by lysis or budding. Most common affliction of humans, replication depends on the ability of the infected host, simple organism, usually self-limiting. Transmission is either aerosol, infected blood, sexual contact, or vector. It's not capable of independent reproduction. It needs permissible hosts through attachment, penetration, uncoating, replication, assembly, and release. It copies of the genetic material made, new virus released from cell to infected other host cells, and some remain latent in the host cell until activation of stress hormone changes the disease. Cytopathic effects of virus inhibit the host cell DNA, RNA, or protein synthesis, disrupt lysosomal membranes, release enzymes that damage host cell, transformation of host cell to cancer cells, promote the secondary bacterial infection, fusion of infected adjacent host cells to produce giant cells, alteration of the antigenic properties of the host cell can lead to immune system attack of cells as foreign. Transformation of a host cell into cancer, for example, would be HPV virus can go into cervical cancer. So fungal infection, molds are aerobic and yeasts are facultative anaerobes, which adapt to but do not require anaerobic conditions. They produce by simple division of budding. Pathologic fungi cause disease by adapting to the host environment. Fungi that colonize the skin can digest keratin. Other fungi can grow with wide temperature variations in low oxygen environments, and others can suppress the host's immune defenses. Phagocytes and T lymphocytes are important in controlling fungi. Low white count promotes fungal infections. Large microorganisms with thick, rigid cell walls without peptoglycans resist penicillin and cephalosporins. They do prefer suppressed immune defenses. Diseases caused by fungi are called mycosis, superficial, deep, and opportunistic. Fungi that invade the skin, hair, nails are also known as dermatophoses. The diseases they produce are called tinea, Artinias, ringworm, Tinea capus, Tinea pedis, and Tinea crucis. Yeast is an opportunistic infection. It changes the normal flora and fosters fungal infections. Deep fungal infections are life-threatening. Parasitic infections, they are symbiotic. They establish a relationship in which the parasite benefits at the expense of the other species. Unicellular protozoa to large worms. Protozoas include malaria, they are amoebae or amoebae dysentery. There is a flagellates, which is Giardia lamblia, which causes diarrhea. There is trypanosomia, which causes sleep sickness. These are less common in the U.S., but are very common in developing countries and play a significant effect on the mortality and morbidity of individuals. Malaria is one of the most common infections worldwide and causes the most deaths. Many protozoan parasites are transmitted through vectors or ingested. Some of the vectors are certain flies, fleas, or mosquitoes. Many times the food and water is contaminated, and most and they are most common in developing countries. They spread from human to human via vectors and are usually ingested. Tissue damage is secondary to infestation itself with toxins, damage from inflammatory or immune response. So countermeasures. This is infection countermeasures, reemergence of some diseases due to lack of implementation or breakdown in application. Most of the breakdown has been in less developed countries. Um, and this is usually environmental measures, meaning waste disposal, water treatment, and contamination prevention, food safety, insect vector control, or safe insecticides. Vaccines are biologic preparations of antigens that, when administered, stimulate production of protective antibodies or cellular immunity against specific pathogens without causing potentially life-threatening disease. The goal is to give lifelong lasting protective immune responses. We do have to give boosters to establish long-term immunity, to get a secondary response from a large number of memory cells, and to sustain protective levels of antibody or T cells, or both. Smallpox is a great example of this. Back in the 1950s, there were 50 million cases of smallpox each year and 15 million deaths. For 10 years, they gave a global vaccine push through the WHO. By 1979, smallpox was eradicated. I remember staying in line in first grade to get the shot in 1977, and they used it was like a pressure gun. They gave us like this multiple shot thing. Oh, it was awful. It was a pressure thing. It was awful. And I remember staying there, and we knew every kid went in this room, and they came out crying. So we didn't know what we were getting, but we knew it wasn't pleasant. And I know it did give us all a scar, but overall, smallpox was eradicated, so it was great. The CDC is who updates our vaccine schedule. The website for this is www.cdc.gov/vaccines/recs/default.htm. There is also an app on your phone that you can download. If you put in vaccines, they'll come up. To develop a successful vaccine is costly. It depends on many things. They have to identify the immune response appropriate to the antigen to induce the response. And when we're talking viruses, they usually are a live vaccine that gives us a controlled response to only express an appropriate amount of the antigen, but not the infection, which is kind of key, because we don't really want to get the infection or the virus. If using an antiquated virus, it can be life-threatening infections. Like, for instance, oral polio vaccine was one that caused polio in immunocompromised patients. Now we use the Salk vaccine, which is inactivated and it's given by injection. Some vaccines are toxoids, which are purified endotoxins that have been chemically detoxified without the loss of the immunogenicity. Example of this is the DTaP, the diphtheria, tetanus, and pertussis vaccine. There is reluctance to vaccinate, and usually this is generally based on potential vaccine dangers. Most of the time, the biggest danger with the vaccines is pain, redness at the injection site, fever. There is some allergic reactions to the vaccine ingredients. It could be infection to, if they're immunodeficient individuals. There are some more severe dangers that do exist, but they're very extremely rare. Most of the time, it is based on misinformation. Most people worry about thimerosal or mercury in the preservative of the vaccine. It has not been routine vaccines since 2001, with the exception of the flu vaccine. And you can get it mercury free because we give it mercury free to all of our OB patients. We do have a passive immunotherapy, and that is given in the form of immunoglobulin, and this is for persons that to help them to get antibodies immediately, and this is if they've been exposed to Hep A, Hep B, or rabies. So, antimicrobials, bactericides kill the microorganisms versus bacteriostatic inhibits the growth until the microorganism is destroyed by the individual's own protective mechanism. The mechanics of action of most antibiotics is number one, it inhibits the synthesis of the cell wall. 2, it damages the cytoplasmic membrane. 3, it alters the metabolism of the nucleic acid. 4, it inhibits protein synthesis, interferes with the folic acid metabolism. Antibiotic resistance to a single antibiotic has rapidly progressed to multiple antibiotic resistance. So antibiotic resistance is due to genetic mutations. So we've had plasma exchange or incorporation of the free DNA. 2, inactivation of antibiotics would be the best example of penicillin resistance, modification of target molecule, increasing active efflux of antibiotics. And what has caused the antibiotic-resistant microorganisms to appear is lack of compliance with therapeutic regimen. Because they don't finish them, obviously, it allows selective resurgence of the microorganisms, overuse of antibiotics, and destruction of normal flora. And then we have overgrowth. So, immune deficiencies. We have failure of immune mechanisms of self-defense. Primary immune deficiency is genetic. Our secondary is acquired immune deficiency, could be caused by other illnesses such as cancer, infection, or normal physiological changes such as aging. So, immune deficiencies, clinical presentation, development of unusual or recurrent severe infections, most severe in young children under 2. Should think about immune deficiency. Individuals have experienced severe documented bouts of pneumonia, otitis media, sinusitis, bronchitis, septicemia, meningitis, or infections with rare opportunistic microorganisms. T cell deficiencies, they get certain viral infections, yeast, atypical microorganisms, B cell and phagocytic deficiencies, microorganisms requiring opposition, encapsulated bacteria, or with viruses against humoral immunity is normally effective, like example of rubella. Complement deficiencies is a C3 deficiency and most severe defect because it is central role in the complement cascade, loss of C3b and C3a production, and the inability to activate C5 results in recurrent life-threatening infections at an early age. They can also affect C5, C6, C7, C8, and C9 deficiencies, which are associated with the increased infections with only one group of bacteria, those of the genus Neisseria, which is usually localized infection. The other deficiency may be um, Manrose binding lectin, which is uh, a defect wall um, in the alternative pathway, resulting in an increased risk of infection with microorganisms that have polysaccharide capsules in which a mannose, I think I said mannose early, mannose, particulating the yeast saccharomyces, Saccharomyces um, cer- cerevisiae. Cerevisiae. Just so you can see what human immunodeficiency virus looks like, it's on page 195. This just is the pictorial for that. So, human immunodeficiency virus infects and destroys the CD4 positive Th cells, which are necessary for the development of both plasma cells and cytotoxic T cells, which are necessary for the development of both plasma cells and cytotoxic T cells. Therefore, HIV suppresses the immune response against itself and secondarily creates a generalized immune deficiency because it suppresses the development of the immune response against other pathogens and microorganisms over time. This will progress to acquired immune deficiency syndrome. Typical routes of transmission: blood products, intravenous drug abuse, both heterosexual, homosexual activity, maternal-child transmission before or during birth. Clinical manifestations: early stages of HIV usually present with relatively mild, nonspecific symptoms resembling influenza, such as headache, fever, or fatigue. These symptoms disappear after 1 to 6 weeks, and although individuals appear to be clinically latency, the virus is actively proliferating in the lymph nodes. Serologically negative, serologically positive, but asymptomatic, early stages of HIV or AIDS. Window period: during the initial phase, antibodies against HIV-1 are not yet detectable. The cells, um, the Th cells, are less than 200 cells per mm3, diagnostic for AIDS. The diagnosis of AIDS is made in association with various clinical conditions and lab tests. Atypical or opportunistic infections and cancer indications of debilitating chronic disease, wasting syndrome, recurrent fevers, presence of antibodies against HIV. They have to have the reduced CD4 T cells numbers below 200, a Western blot analysis. Without treatments, the average time from infection to development of AIDS is just over 10 years. AIDS pathogenesis. Um, it is a retrovirus. Genetic information is in the form of RNA. It contains reverse transcriptase to convert RNA into double-stranded DNA. The current treatment for AIDS is antiretrotherapy, or ART. Protocols require a combination of synergist drugs from different classes, and specific regimens are adapted based on the age of the individual, secondary clinical symptoms, CD4 and T cell levels, viral loads, specific co-infections, pre-existing cardiac risk factors, past history of treatment failure, suspected drug resistance. We will have to see where research takes us over time with this medication or with this disease. It's interesting because they lean towards that it'll be a vaccine that actually gets this under control. Right now, it's a chronic disease. So, when we're talking about evaluation of immunity, obviously you guys are all nurses, and we know it's going to be complete blood count with a differential. Okay, we're going to be looking at um, in subpopulations, we're going to look at our lymphocytes, quantitative determination of immunoglobulins, and we're going to look at our different complements, our assay for our total complements. And as we're looking at this, we're going to talk about hypersensitivity disorders. We've got allergy, which is going to be typically our hypersensitivity to environment, our autoimmunity, disturbances in the immunologic tolerance of self antigens, alloimmunity, immune reaction to tissue of another individual. And we're going to talk about all the different types of hypersensitivity. Type 1, which is IgE mediated. Type 2, tissue specific. Type 3, immunocomplex. Type 4, cell mediated. Immediate hypersensitivity reactions, anaphylaxis, and delayed hypersensitivity reactions. So, our type 1 hypersensitivity reactions are mediated by antigen-specific IgE and the production of tissue mast cells. Most common IgE mediated, it's against environment, antigens, or allergens. IgE binds to Fc receptor on the cell of mast cells, and we're sensitized. Histamine release from the mast cell degranulation. H1, H2 receptors. Antihistamines can block some H1 responses. We're going to have some manifestations. So it could be a GI allergy where we have nausea, vomiting, diarrhea, and abdominal pain. We can have some skin manifestations, which will be urticaria and hives. Mucosal allergens. We can have conjunctivitis, rhinitis, and asthma. We can have lung allergens, bronchospasm, edema, thick secretions. Genetic predispositions. A topic: one parent has an allergy, 40% of the offspring will probably have it. If both have it, 80% of the offspring will produce high quantities of IgE. Most and more Fc receptors for the IgG on their mast cells. Usually we will test with food challenges, skin tests, laboratory tests for total IgE and allergen-specific IgE. You can do desensitization cautiously, but that's extremely cautiously. Okay, so this is the type 1 hypersensitivity pictorial, which I think is self-explanatory. Thanks. So your type 2 hypersensitivity are generally reactions against a specific cell or tissue. Cells express a variety of antigens on their surface, some of which are called tissue-specific antigens because they are expressed on the plasma membranes of only certain cells. Platelets, for example, have groups of antigens that are found on no other cells of the body. The symptoms of many type 2 diseases are determined by which tissues or organs express the particular antigen. 5 mechanisms by which type 2 hypersensitivity reactions can affect cells are shown. Cells are destroyed by antibodies and complement. Cells destruct through phagocytosis. Soluble antigens may enter the circulation and deposit on tissues. Tissues destroyed by complement and neutrophil granules. Antibody-dependent cell-mediated cytotoxicity. target cell malfunction, which is like Graves. So your type 3 hypersensitivity diseases reactions are caused by antigen antibody immune complexes that are formed in the circulation and deposited later in vessel walls or other tissues. Type 3 hypersensitivities are not organ specific. Some examples are serum sickness. This is type of reaction are caused by the formation of immune complexes in the blood and their subsequent generalization deposition in target tissues. This was caused from um, being given tetanus toxins way back when. Another example is Raynaud's phenomenon, a condition caused by temperature dependent having a temperature dependent deposition to immune complexes in the capillary beds of the peripheral circulation. So this is triggered by low temperatures, and the chiroglobulins then block the circulation to the tips of the fingers, toes, and nose, and they develop a localized pallor, numbness, followed by cyanosis, and eventually they can get gangrene if the circulation is not restored. This can be very painful. Arthus reaction is caused by a repeat local exposure to an antigen that reacts with performed antibodies and forms immune complexes in the walls of local blood vessels. Symptoms start within 1 hour of exposure and peak 6 to 12 hours later. So, a type 4 hypersensitivity reactions are mediated by T lymphocytes and do not involve antibodies. Cell-mediated hypersensitivity reactions does not involve an antibody. Its cytotoxic T lymphocytes are lymphokine producing Th1 and Th17 cells. They direct killing by Tc or recruitment of phagocyte cells by Th1 and Th17 cells. So examples of this is graft rejection, tuberculosis skin testing, allergic reactions from poison ivy, metals. So this is your contact dermatitis, typically. So allergy, most common hypersensitivity and usual type. One, it's environmental allergens caused by atypical immune response in general predisposed individuals, pollens, mold, fungi, food, animals. Often the allergen is contained within a particle too large to be phagocyte, phagocyted, or is protected by a non-allergic coat. But one example of this that's not pleasant is bee stings. Autoimmunity, it's disease originated from an initiating event in a genetic predisposed individual. Systemic lupus erythematosus, rheumatoid arthritis, or psoriasis are all examples of this. And it's usually due to a breakdown or a tolerance that the body recognizes as a antigen as foreign, and so it's essentially attacking itself. So systemic lupus erythematosus is the most common, complex, and serious of the autoimmune disorders. SLE is characterized by the production of a large variety of antibodies against self-antigens, including nucleic acids, erythrocytes, coagulation proteins, phospholipids, lymphocytes, platelets, and other self components. Facial rash, it's manifested by facial rash confined to the cheeks, discoid rash, photosensitivity, oral nasopharyngeal ulcers, non-erosive arthritis of at least two peripheral joints, cervicitis, inflammation of the lungs, renal disorder, neurologic disorders, hematologic disorders, immunologic disorders, presence of an ANA, a positive ANA. No cure for SLE. Sometimes controlled symptoms with NSAIDs, corticosteroids, or non-malarial meds. Alloimmunity is immune system reaction with antigens on the tissues of other genetically dissimilar membranes of the same species. Transfusion reactions. So this is your ABO group. So um, the A and B carbohydrate antigen can be simultaneously expressed, meaning that's somebody with blood type AB, or it can have neither, which would be O, or it can just be A when they have A only or B only. So, example would be if somebody with type A can only have type A blood because they can't have AB or B because then their erythrocytes would destroy it. Type O is the universal donor because they can give to everybody because they don't carry any of the antigens, and a B can receive from is the universal recipient because they have all the antigens. But we always try to match up because we don't want them to develop. We don't want them to have a reaction. So that's why we give the blood that you are supposed to have. And then we go into our Rh blood group. So those are antigens expressed only on the RBCs, and somebody is either Rh positive or Rh negative. So then on top of making sure they're A, B, or O, we have to make sure they're either Rh positive or Rh negative. And so then we match that up. Now, we also have what's called hemolytic disease of the newborn, which was commonly caused by IgG anti-D alloantibody, which was produced by Rh negative mothers against the erythrocytes of their Rh positive fetuses. So the mother's antibody crossed the placenta and destroyed the red blood cells of the fetus. Because what happened is they had a previous fetus that was positive, and then they had another fetus that was positive, and then their body attacked it, essentially. So the occurrence of this particular form of the disease has decreased dramatically because of the use of prophylactic anti-D immunoglobulin. So we give this if there's any bleeding. So if somebody bleeds, like has a miscarriage or has any bleeding spotting, we'll give that while they're pregnant and at 28 weeks and at delivery so that they do not build antibodies for future pregnancy. We discussed MHC molecules earlier, but they are important in a major target of transplant rejection. As a result of studies of transplantation, the human HC molecule are also referred to the human leukocyte antigen, HLAs, and the different MHC genetic loci are commonly called HLA-A, HLA-B, HLA-C, HLA-DR, HLA-DQ, HLA-DP. Additional genes for complement components are also contained in the MHC region and are referred to as class II loci. The diversity of the MHC molecules become clinically relevant during organ transplantation, and the recipient can mount a response to reject the transplant. Hyperacute rejection is immediate and rare. This is due to type 2 reaction. An acute rejection is a cell-mediated immune response that occurs within days to months after transplantation. This type of rejection occurs when the recipient develops an immune response against unmatched HLA antigens after transplantation. A biopsy of the rejected organ usually shows an infiltration of lymphocytes and macrophages, characteristic of a type 4 reaction. Chronic rejection may occur after a period of months or years of normal function. It is characterized by slow, progressive organ failure. Weak cell-mediated reaction against minor histocompatibility antigens on the grafted tissue. We made it, guys. I know it was long, sorry, but we're done, and hopefully I'll get the other lecture out to you no later than Monday. But you can see these take forever. These first three, because this class was new to me last semester, were borrowed, and so they're all newly getting written this time. After that, they're all done. So hopefully we'll get caught up here after these first 3 weeks. Thanks.